So thank you so much for the introduction, and thank you to the Equalize program and to my mentor, Nancy Pryor. I'm presenting a novel intravenous therapy for respiratory failure or for the more severe acute respiratory distress syndrome, ARDS, which can be caused by COVID-19 or by other conditions. There are a variety of systemic and pulmonary conditions, the latter of which include pneumonia due to SARS, MERS, and COVID-19, which can lead to ARDS. And inflammation is a prominent component of all of these conditions. So the inflammation causes lung injury. The capillaries in the lung become leaky, they become permeable, liquid and the protein albumin leak out of the blood vessels into the airspace, which floods the airspace and reduces gas exchange. These patients have trouble breathing, they have acute respiratory failure, and that can progress to full-blown ARDS. The treatment is mechanical ventilation, and this is really a catch-22. It supports gas exchange and helps keep patients alive, that's great, but at the same time, it causes a mechanical overdistension injury of the lungs. With each breath, it overdistends the lungs, which exacerbates the inflammation. And that's known as ventilation-induced lung injury, or VILI. And VILI prevents patients from recovering. So there's this injurious feedback loop. And I'll point out that a therapeutic that could reduce VILI and reduce the exacerbation of inflammation would be acting midstream in the disease process. The mortality for ARDS is 35%.
No.
This number is better than it was because there are a couple treatments that have been beneficial. The two therapies that have worked are mechanical interventions, ventilating patients with a very low breath volume to avoid the overdistension, or positioning patients prone on their stomachs. These mechanical interventions reduce the mechanical exacerbation or overdistension injury of the VILI. There have also been a host of pharmacologic therapies that have been tried. Generally speaking, these target downstream targets in the inflammatory pathways, and essentially none of them have been effective. The sole exception very recently is steroids for COVID. For many years, the great hope was for surfactant therapy. And I call this a hybrid therapy because it's a pharmacologic substance intended to have a mechanical effect. The substance is surfactant produced in the lungs. It's harvested from animal lungs and instilled in the trachea. But surfactant is intended to lower surface tension in the lungs, which should reduce the VILI, the ventilation injury. And that's a mechanical effect. And I'll get more into that link on the next slide. 6 randomized controlled clinical trials, not one of them reduced mortality. Why not? It could be that instilled in the trachea in adult lungs, which are large, it's just not getting to the distant regions of the lungs. So now, why should lowering surface tension lower VILI? Well, this is my area of expertise. In healthy lungs, the alveoli, which are the smallest air spaces, and shown in red here, are separated by septa that are planar. The alveoli are also lined by a thin liquid layer in blue, and so there's an air-liquid interface with surface tension acting at it. Surfactant produced by our lungs, shown in purple, acts at the air-liquid interface to reduce surface tension. In ARDS, there's heterogeneous flooding of the alveoli, which is known as edema. And so you have interspersed aerated alveoli in black with flooded alveoli in green. And the septa between them are no longer planar, they're bowed. And that bowing means that they're overdistended. Further, we've found that that bowing is proportional to surface tension in the lungs. In ARDS, surface tension is elevated. Additionally, lung inflation further increases surface tension. So every breath increases surface tension, exacerbates that bowing or overdistension, and contributes to the VILI. Therefore, lowering surface tension should reduce VILI. So to lower surface tension, I'm introducing a novel pharmacologic, sulfurrhodamine B. It's a fluorescent dye and a small molecule. Preclinical toxicology by oral administration is supportive of use in humans. It's approved as a food dye in Japan. It lowers surface tension in a novel fashion. It actually interacts with the albumin, which also comes out of the bloodstream. And the two together improve the efficacy of the native surfactant in the lungs to reduce surface tension in the lungs. We're proposing that it be administered IV, which is a novel route for a surface tension lowering therapeutic. It's also an effective route because we give it via the bloodstream. It leaves the bloodstream and goes into the airspace of the alveolus, precisely where capillary permeability is elevated, so exactly where the lungs are injured and where it is needed to act. And it's potentially the first pharmacologic therapy for general ARDS. Like surfactant therapy, it would be a hybrid therapeutic, a pharmacologic substance intended to have a mechanical effect, lowering surface tension, reducing the villi. I have two slides of preclinical data which constitute the rationale for why SRB should be developed as a therapeutic. Here, in isolated rat lungs, we flooded alveoli with solutions containing substances purported to raise surface tension in ARDS. We found that in conditions modeling COVID ARDS and 88% of non-COVID ARDS, SRB markedly reduced surface tension generally all the way to normal. Then we tested SRB in vivo in anesthetized ventilated rats with model lung injury. We found that it lowered surface tension all the way to normal, specifically in injured lung regions. It caused a significant reduction in a metric of the degree of edema in the lungs. It markedly increased oxygenation. And think about this, if you could increase oxygenation, you might not need to ventilate the patient and you could avoid the villi. And it reduced half of the levels of half of the plasma markers of injury and inflammation that we assessed. So SRB can be given IV, it reduces villi, and it improves oxygenation. The market potential for SRB is substantial. The incidence in the US for respiratory failure or ARDS is estimated to be between 40 and 200 per 100,000 per year. 83% of those individuals are mechanically ventilated, and again, there's this injurious feedback loop. So mortality for that general population is 35% and slightly higher at 40% for those who are mechanically ventilated. In COVID, amongst hospitalized patients, roughly a third developed respiratory failure, and about half of those, or 16% of hospitalized patients, were mechanically ventilated. Mortality ranged from 30 to 60%. Administration of SRB prior to mechanical ventilation could reduce progression to ARDS and reduce the need for mechanical ventilation. Administration along with mechanical ventilation could reduce mortality. And beyond this population, there's a strong case to be made for prophylactic SRB administration to individuals with a variety of conditions, sepsis, shock, pancreatitis, pneumonia, who are at risk for ARDS. This is an opportunity to act at the very upstream end of the disease progression to prevent the development of respiratory failure, and this would markedly increase the market for the therapeutic. Strengths and weaknesses. We have 2 issued patents for SRB which cover the full dose range. The dose is very small for SRB, and which cover both IV and airway administration. We have an issued patent and a continuation application from 2015 for an alternative peptide therapeutic, and a recent provisional application for dual administration via vasculature and airways at the same time. There is no existing pharmacologic therapy for general ARDS, and this is not a condition for which there's likely to be a silver bullet. So SRB should complement existing and future mechanical and pharmacologic therapies. Weaknesses are that our patents for SRB are US methods patents from 2011, and the opportunity is the clinical endpoint to save lives. We aim to reduce mortality below 35% in non-pandemic ARDS COVID ARDS, and in the next epidemic or pandemic. We've received 3.3 in funding for preclinical studies, 2.3 of which has been devoted to SRB. I'm asking for $5 million to prepare an IND application for CMC, safety and toxicology testing, and regulatory support. And anticipate that a subsequent funding round will be gated on results of GLP safety studies and acceptance of an IND application. I'm supported by advisors from tech transfer within academia, individuals with leadership experience in the pharma industry, and by a clinician who is really a world expert, world leader in designing clinical trials for ARDS. And so in conclusion, IV SRB can reduce the need for mechanical ventilation and increase survival in ARDS. If you're interested in further information, I'd welcome your contacting me. Thank you.
Terrific, wonderful. Thank you so much, Carrie. Chris, do you want to go first this time?
Sure. Carrie, can you go back to the preclinical slide, if you would?
Yes.
That's easy enough. The data you had. Yeah, the next one. So I'm just trying to understand the asterisk is there. What the control has an asterisk, or is that just?
Okay. So the control is elevated above normal.
Okay.
That asterisk, and then the pound sign is the difference between the control and the therapeutic.
On the edema, though, you have two asterisks. Is that?
They're both elevated above normal. The
Okay.
Therapeutic does reduce the wet to dry ratio, which is a metric of degree of edema. It does not reduce it down to normal. This is obviously a very small difference.
Yeah.
But the oxygenation data show how sensitive the lung is to even a small reduction in the amount of water in the lung. You can get a big improvement in oxygenation.
Yeah, that's what I was getting at, because the surface tension is impressive, right, to get that down to normal, but I didn't see that translating the edema. And on the oxygenation, I would have expected maybe the separation to happen earlier. Why is it taking 3 to 4 hours to see that?
This is a progressive disease, so this is not going to reverse anything that happens. It is going to prevent conditions from getting worse. So it will definitely be important to give it early. The latest I would give it is at the implementation of mechanical ventilation, but I would ideally give it even sooner, prophylactically, before you start mechanically ventilating.
Yeah.
Even
and then I would just a suggestion on the marker movement. I think it's always good to see the actual bars on that and the change of those.
Sure.
Yeah,
we
but that's
do
all.
have it published, and I'm happy to.
Great. Thank you so much.
Great. Christine.
Off mute first. Yeah, thank you. Really interesting and very timely, obviously. Quick question on the patent situation. You had mentioned that there's a method of use patent, and I'm just wondering, knowing how difficult it is to get people excited if it doesn't have composition of matter, are there thoughts around taking this towards something that would have composition of matter, or any other insights that you glean from doing this to maybe have this and something else to make it even better?
Mm-hmm. There's certainly the possibility of going after composition of matter. That's probably the main question I get asked. We do not yet know the molecular mechanism through which this works. So we know there's a charge effect. SRB and another rhodamine dye, which both have an iminium cation on them, a positive charge, work. Sulfurrhodamine G, which lacks that positive charge, doesn't work. So there's a charge interaction. We have not yet been able to replicate the efficacy in vitro. And that's a good problem. I would rather be able to do this in vivo than in vitro if I had to choose. We are working on it, but it's a road ahead to replicate it in vitro so that we can elucidate the mechanism. And then it's an open question, will we find composition of matter that has a benefit over what we have now and is this clean on toxicology? So I am certainly interested in learning how this works, and we're going after it. I can't tell you whether we will get there or not.
Thank you.
All right, Meghana, do you have a quick one?
Yeah, just any thoughts on potentially using this in preemies? I know sometimes, right? I think take surfactant when they're born too early.
Right. So thank you for asking that. Yeah, surfactant therapy, for those who don't know, is a marvel in neonates. It's why premature babies can be kept alive, and it's not entirely clear why that hasn't translated to adults. I do suspect that this could complement or even replace surfactant therapy in neonates. So I think that's a really promising additional market. And our recent provisional patent application, which we filed earlier this year, specifically does look at administering this IV while surfactant is given via the trachea, looking forward towards a neonatal market.
Thanks.
Great. Thank you.